We're finishing up the chapter on blood, and then we're going to go on into the chapter on the heart. And that's going to be a lot of good information for you because you have your heart eval next week. And so all of the information that we talk about heart anatomy for you is going to be very important because you should be using that information when you actually prepare what I call your skit for your heart eval. Because your skit should just be 2 skits. 1 skit for the right side and 1 skit for the left side. And what will happen that you actually don't realize, you will name every single structure in the heart anyway. And the things that you don't name are actually important because then it actually does show you do know what the right side of the heart is or the left side of the heart. So you will actually name 95% of the structures no matter what side we give you. So in essence, you do have to know everything about the heart. But it's the anatomy of the heart. It's what you can see. It's what you can touch. It's not what you can't see. It's not what you can't touch. So realize you are to identify anatomy of the various structures of the heart. Always best to start with where you go in and always best to finish with where you go out if it's right side or left side. So, and also I think your lab instructors will have you follow a certain protocol for your naming, and that is you will typically start with naming features in common to both sides and start external. Don't go too much internal because you will go internal when you're given the right or the left side. So everything about the heart external and for sure things in common to both sides. So when you talk about the anterior interventricular sulcus, is that in common to both sides? Yes. So things along that line is what you're going to need to do. So that's write everything down for every absolute feature of the heart that you can identify physically, and then start to put them into right side, left side, and there'll be things that will be obviously in both lists, correct? Things in common to both sides. So keep that type of arrangement and you'll do well. The final aspect of blood, we were on coagulation. We're in hemostasis, and coagulation is the 3rd phase of hemostasis, the stoppage of blood flow. First phase is a nervous system related process. The sympathetic nervous system would be something that you would actually relate it to, and that is vasospasm or vascular spasm designed to minimize the loss of blood. The smaller the vessel, the easier it's going to be. The larger the vessel, the more difficult that's going to be to minimize the loss of blood. And hence people come around and do their own versions of vasospasm. If somebody gets their leg cut off, they actually go ahead and put a tourniquet around their thigh, correct? And so that's their method of trying to actually stem the loss of blood. So that's what vasospasm is all about. And it's a nervous system response, so it's fatigable, lasts about 30 minutes. However, hemostasis and the formation of the clot only takes 3 to 6 minutes. So this mechanism is designed in case there's something else going on that's slowing down the normal clot formation process. The next step that's important for that is then the RAG or platelet plugs. And so the platelets are designed to actually be your body's little internal rag that will actually go in there and fill up that defect for you as a temporary factor. So it's only there temporarily, and it's designed to also augment the following step of that coagulation of the formation of that clot. And so in coagulation, we have some terminology we were defining, and we have procoagulants. Those are plasma proteins that are typically made by the liver. They're floating around in your bloodstream, predominantly in an inactive form, because if they were in an active form, you wouldn't be here anymore. You'd be in the hospital. They'd be giving you anticoagulants in the hospital and trying to figure out why you have a procoagulant process. Sometimes some cancers actually cause people to be more prone and activate their procoagulants up. So that's one of the things that actually can make things backwards for you. You actually have also anticoagulants naturally occurring in your bloodstream, and they're there because they're meant to dominate the system so that blood flows freely so that we have the proper transfer of oxygen to our tissues and the removal of carbon dioxide and waste from our tissues. So we do have that domination of our anticoagulants. We talked about aspirin is commonly used over the counter and also prescribed to help, quote, thin your blood. And when people say they're thinning your blood, they're trying to stop this coagulation process, correct? They're not really trying to thin your blood because thinning your blood would make you anemic, right? So they are trying blood thinners are designed to keep you from clotting. So aspirin is one, also Coumadin, or also known as warfarin, is another. That's an old trade name, and then heparin is another one. There's some others that you see advertised over on TV that you have to have a prescription for, and trust me, those are always the more expensive ones out there. So there's more than just these that are prescribed by physicians and healthcare providers. Thrombus, embolus, and hemophilia. Two are very similar, one is very different. Thrombus and embolus are related because a thrombus is a clot that will develop inside the lumen of an unbroken vessel. The thrombus can partially obstruct the lumen of the vessel, which means you still have blood flow, or completely obstruct the lumen of the vessel, which means then you will no longer have any more blood flow. And that is important because if it's an incomplete obstruction, you still have blood flow, so you still have end organ, the organs at the end of that blood vessel are still getting some of the nutrients that they need and therefore getting rid of their waste. But they can actually cause some symptoms because you're not getting adequate nutrient delivery. And that's where sometimes people have partially obstructed coronary arteries, correct? They'll get a symptom called angina. And that's because they're exerting themselves and they don't have a lumen large enough to actually take care of the increased needs that the organ is actually having. So that's a thrombus, so a clot that develops inside a vessel. Now, over time, clots organize. What that means is they no longer look like a clot. Your body actually goes in there and makes some structural changes, and that clot will stay in its place if it's a thrombus. Now, an embolus is a portion of a thrombus that breaks off. And when it breaks off, it flows downstream, correct? It's not going to flow upstream. It's going to flow downstream. And depending upon the vessel, because these things can occur in arteries or veins, they're more lethal initially if they occur in arteries, but also if they occur in veins, they can also be lethal, especially for people who fly long distances in airplanes, correct? You guys have heard about people dying from blood clots that embolized to their lungs. And so this clot started in a vein for those people. And what do we know already? What do you guys know about arteries and veins? As you are an artery and you're following the artery, does the vessel lumen get larger or smaller as you follow the artery along? Smaller. So that's real important. Now, if you're in a vein and you're following the vein, which is always taking blood, not used blood, always taking blood back to the heart, what happens to the vessel diameter? Gets larger. So that's the thing that actually dictates when you're going to notice an embolus. If the embolus starts on the arterial side, you'll notice it right away. If it starts on the venous side, there's going to be a delay because venous blood is all, and that's one of your definitions. You guys should have this absolutely written in your notes as the hard and fast rule for the difference between an artery and a vein. An artery always takes blood away from the heart. A vein always takes blood back to the heart. And that's real important because you guys always think arteries carry oxygen-rich blood because that's the pictures that you have seen, and you haven't looked at the pictures really closely. But if you are a pulmonary artery, you're taking oxygen-poor blood to the lungs for oxygenation. And then if you're a vein, you're a pulmonary vein taking blood back to the heart, you're always taking oxygen-rich blood back to the heart to be pumped out to the systemic circuit. So that's why you have to remember this definition is totally different than the definitions of the color coding thing or oxygenation of the blood. Arteries always take blood away from the heart, and veins always take blood back to the heart. That's another reason why an embolus that starts in the vein typically starts in the leg veins. So DVT, deep vein thrombosis, is the thing that they actually say. So a thrombus is actually occurring in the leg veins, and then something breaks off. When that something breaks off, it's called an embolus, and it's going into a larger vessel and a larger vessel and a larger vessel and a larger vessel until it gets to the heart. And whenever veins get to the heart, we're going to be talking about heart anatomy anyway, so we might as well start right here. When the vein gets to the heart, what chamber does it enter? Because there's only two main chambers that the heart has. What main chamber does a vein always dump its blood into? An atrium, correct? Veins always take blood to the heart And always that blood is emptied or delivered to your atriums, always. And then, is an atrium larger than a vein? You better believe it. Okay, so you're not going to experience any problems still because we have this little bullet and or this BB traveling into larger and larger structures. It's not going to cause any obstruction anywhere. So it gets into the atrium. From the atrium, it always goes into the ventricles. And from the ventricles are always pumping blood away from the heart. And so ventricles are nice and muscular, and the blood vessels that are responsible for taking blood away from the heart are always muscular. So arteries are always muscular when you compare them to veins. It doesn't mean veins don't have muscles in their walls, but arteries are always muscular when you compare them to veins. So it goes into the ventricle, which is larger than the atrium, correct? You're not going to notice it there. But when it leaves the ventricle, it now goes into the plumbing system. That's the arterial system. And we know as we follow that arterial system away from the heart, the vessel diameter is going to get smaller and smaller and smaller. And so you will always experience it in the arterial side. Now, if this is taking this little BB into the right side of the heart, as you guys are learning already in lab, that's why we can talk about it before we get into lecture. It goes into the right atrium. From the right atrium, it goes into the right ventricle. From the right ventricle, it goes into the pulmonary trunk. And from the pulmonary trunk, it goes to the lungs. And there you suddenly cannot breathe because you have blocked, you can breathe, but you can't because the reason you breathe is to oxygenate your blood. So you can breathe all you want. It won't matter because the reason for breathing is now blocked in a very important segment of your lungs, and that is compromising your actual ability to oxygenate your blood and to survive. And that's what a pulmonary embolus is all about. You guys follow me with that? That's the story of a pulmonary embolus. Pulmonary embolus are almost always, there's always going to be an exception to the rule, are almost always of venous origin. So thrombus and embolus. Now we have a good understanding of the importance of the two. Hemophilia, that's a free bleeder, and that is because somebody doesn't have a procoagulant. So lack of a clotting factor means lack of a procoagulant. So they are genetically deficient or they have a malfunctioning, therefore non-functioning procoagulant. And for those people to not have the bleeding problems that they do, they have to get regular factor transfusions because we call these procoagulants factor transfusions. So they get regular transfusions that will hang around in the bloodstream until they actually deteriorate. And so that's one of the reasons why those people who are hemophiliacs, who get frequent blood transfusions or factor transfusions, which they get from the blood, have an unfortunately higher risk of blood-borne diseases such as HIV and hepatitis. So, and that's because, we've acquired better and better testing techniques, correct? With better testing techniques, we do not inadvertently infect people with these diseases because we throw that blood away. We don't actually use that blood. But that's part of the reason why some of these people actually do have HIV or hepatitis B or C, and that's because we didn't catch it with our older tests, and now we're much better with that. So blood transfusions, they'll still tell you they have a risk associated with them, correct? You may not realize it. All treatment has a risk associated with it, yes? So blood transfusions are a risk, but remember, people don't give you blood because A, one of the things that's hard to get blood, you have to get people to volunteer to give blood for the blood bank. And B, they want to make sure that you're safe no matter what happens to you. And that's the goal. First goal in healthcare is do no harm. So that's the first goal in healthcare. Now let's talk about this formation of a clot. It involves now what's called an enzyme cascade. So a cascade is meant to tell you that this event will then cause the next event to happen, which will cause the next event to happen. It's kind of like dominoes. So once you tip the first one, it will then tip the next one and the next one and the next one on down. And that's one of the reasons why we call this mechanism a positive feedback mechanism. Because most of our feedbacks that we've talked about that bring us to homeostasis are negative feedbacks. Well, this is not the typical homeostasis. We have a hole in a vessel that should never have a hole in it. That's not a homeostatic, that's not a disease process. That's a physical traumatic event. And so we have this cascade of events that are designed to block the hole and then bring the edges together so healing can occur. And then the very last part is that thing which blocked the hole needs to be removed, correct? Because if it wasn't removed, everybody would be at risk for embolus, right? So we need to get rid of that plug, that platelet plug, and all that it entails in the formation eventually of the clot out of the system, and that's what our fibrinolysis is all about. So let's take a look. There are so many factors involved in this enzyme cascade that we only have to learn 3 steps. And so even though this seems like a lot, this is just the tip of the iceberg. So let's take a look at the 3 steps that we want you to know here. Formation of prothrombin activator. We want to make a thrombus. We want to make a blockage here. Not a complete blockage. We just are trying to block the loss of blood in this process. So formation of prothrombin activator. And this involves 5 players. This involves factor 10, and these factors are all the plasma proteins or procoagulants I was talking about. So factor 10 plus factor 2 plus factor 5 plus calcium ions plus platelet factor 3. That's a lot of things to memorize. An easy thing, because I always create little shortcuts for myself in my memorization, factor 10 equals 2 times 5. So already I have 3 things, which tells me platelet factor 3 is also part of this process, and then calcium ions. So whatever method works for you, go ahead and employ it. If straight memorization works for you, I just like, well, 10. As long as I can remember 10, I can probably get a few of the other factors figured out. So factor 10, 2, 5, platelet factor 3, and calcium ions are all involved in making prothrombin activator. And we're going to abbreviate prothrombin activator as PA. This is a slow step, but once this step is started, we're on a roll, literally. Because now prothrombin activator will activate the conversion of prothrombin to thrombin. Pro is for and typically before, and thrombin is now that blockage. So thrombin, however, is not the actual blockage, it's an enzyme. And it's going to catalyze the transformation of fibrinogen, which is the inactive form of these plasma protein, ultimately threads, into fibrin, which is now insoluble, which means now we actually have the suturing material that I was talking about earlier. So now we have the threads in the bloodstream. But all of this is happening right there where the defect is located. It is not happening all throughout the vascular tree. It is happening right there where that defect is actually occurring. So we have prothrombin activator helping to make thrombin, which will then help to make fibrin. And fibrin is a trap. Fibrin threads are truly trapping red blood cells, white blood cells, platelets, and plasma, all in its meshwork. You know, it's like a fishing net. You know, we throw the fishing net out, and then we start to bring it in. And that's the important thing, because now we have that jelly stuff that looks like a clot, the blood jelly. It looks like the clot. And remember, there was a nice scanning electron micrograph up here, which shows you the clot. This is what a clot looks like. And the thing about it is now taking care of all of the blood loss. The next thing that we need to do, though, is we have a defect and we need it to heal, right? We're stemming the tide of blood loss, but we still we need to get rid of this guy because we can get an embolus if we don't get rid of this guy. So in order to get rid of this clot, we now need to bring the cut edges together and heal, and then remember our endothelium will then secrete factors which will help to actually say I'm healthy, but they also will secrete some other factors that we're going to talk about in just a moment. And so that's why clot retraction and fibrinolysis is an important process of the healing phase. We need the clot to shrink and bring our cut edges closer together, because endothelium is like epithelium. And remember, all of our epithelium that we've talked about is very mitotically active. And so they can duplicate themselves and regenerate and repair. So that's what's really good. Interestingly, those little granules that you see in platelets are not just serotonin and ADP and thromboxane A2, they're also actin and myosin. And you guys know that those are proteins found in all muscle cells, and they are designed to actually facilitate the shortening of the muscle cell, or therefore the contraction. And so all those little itty-bitty platelet bodies that are there stuck to the fibrin threads are actually now pulling on the fibrin threads. You know, each one's pulling an infinitesimally small amount, but like our actin and myosin in our muscle, the more you have pulling, those small amounts become larger and larger. And so that brings the wound raw edges closer together, and the closer they are together, the more rapid your healing that will actually occur for you. So that's a really, really cool thing. So now that we've got our clot retraction, like the doctor that you went into the office so he can stitch this big gaping wound closed, that's what we're doing. We put the fibrin threads in, and now our platelets are helping us to actually cinch it up and bring those edges together for that healing process. We still have the clot though. It's smaller, but it's still there. And remember, now that we're healing, we're going to be secreting things to say, don't clot on me, because that's what endothelium does. It secretes things that say, don't clot on me. And we need to get rid of the clot. Before I forget, serum. You may have heard of the word serum, and we've already talked about plasma. Serum is plasma minus clotting factors. So we are using up all of our clotting factors locally in this clot. And so when we squeeze the fluid out, we no longer have clotting factors. And that's what serum is. Because sometimes you hear, well, we'll test his serum. What they're meaning is this blood will not clot, or this plasma will not clot, because it's not, quote, typical plasma now. It's plasma minus clotting factors. And that's why you can not have to worry about a time frame to actually test it, because it won't gel up on you. Now into fibrinolysis. So we want to cut those little threads up. We want to chop up this little clot that we actually have. And this is important because repair is going to get near completion, which means we got our edges together and we're getting ready to secrete various factors. But what's interesting about this healing tissue is that it in itself, besides releasing anticoagulants on its surface, releases something else. Healing tissues, and obviously I'm talking about healing blood vessel tissues, tissue, plasminogen, activator. This is typically abbreviated with a little t, capital P, capital A. And that way you don't mess it up with prothrombin activator. TPA. Has anybody ever heard of this outside of this lecture hall, TPA? TPA is what somebody gets when they go to the emergency room because they're having a heart attack. TPA is so potent, it's known as a clot buster. And so when somebody's having a heart attack and they think it's due to an obstruction of their blood vessel, and that might be due to more clot filling the blood vessel, they'll give them TPA. And if that vessel opens up enough to allow blood to flow through and therefore minimizes any sort of cardiac damage, it's a successful event. So what's fascinating is they found out about TPA because they studied us. Our healing tissues, our blood vessel tissues, when they're finishing up the healing phase, release tissue plasminogen activator. Well, you have that big clot right over you, and now you're releasing tissue plasminogen activator, and you literally digest that enzyme literally will digest that clot away, and poof, it's gone. And so you have no more worry about an embolus or a thrombus or any of that type of stuff. Yes?
So does that cause, number one, the clot retraction?
TPA does not cause, clot retraction is, getting smaller.
How does it get smaller?
The platelets are pulling on the fibrin threads, causing everything to come together and squeezing out the plasma, which we now call serum. So remember, that gelatinous clot is red blood cells, white blood cells, platelets, fibrin, and the reason it's jello-like is there's fluid in there, and it's got that serum in it. So now clot retraction, we're squeezing fluid out, and we're getting smaller in size, and everything's getting compacted together. Because if you take a look at the previous picture, you can actually make that even more compact, and that's what that clot retraction is all about. Platelets pulling on the fibrin threads, bringing everything close together, squeezing things out. So now we have TPA being produced. This will start a local cascade of enzymes which will digest away the clot. It's really cool. And so I've given you the intro to this, and later on, if you specialize in anything, you'll learn more about the various factors that are actually responsible for this clot formation and then the removal of the clot. But tissue plasminogen activator. And can you see from the name even, plasminogen, plasma. So this is meant to actually get everything back to the more fluid flowing state for you. Let's go into the heart, which we've already started to talk about. And I like these pictures because this is what you guys are experiencing in the lab better than the cartoon pictures, which have red for oxygen-rich blood and blue for oxygen-poor blood. So it's important that as you look at your chapters and you look at the cartoons that they've created for you and you look at our various models, red always stands for oxygen-rich and blue always stands for oxygen-poor. And that's important because red isn't always in arteries. Red will also be in veins, and that's why we have to remember our definitions. Now, the top picture that we have here is the anterior view of a cadaveric heart, and the bottom picture is a posterior view of the cadaveric heart. And I tell you, they look very different to me. Now, your pig heart doesn't look like the cadaveric heart, but it is so similar that we actually use pig heart valves for heart valve replacement surgery. So the pig heart is an excellent model for us to use to study about the human heart. And you guys have some giant pig hearts to actually take a look at, so it makes it easier to dissect. And they're more pliable than our older specimens used to be. And pliable means less rigid and easier to manipulate with your hands. Now take a look at the top picture, which is our anterior view. And so remember, as you are holding the heart, doing your heart demo, don't forget to say anterior, posterior, because that shows your instructor that you are properly oriented. And that's what you want to actually be able to do, because that's part of what your task is, to show that you know what you're looking at. So this is our anterior view, and what's important is the apex of the heart is the pointy part of the heart, right? And the apex is always the same whether you're looking at it anteriorly or posteriorly. So it's the pointy part of the heart. So this is the area, and it's in common to both sides. The base of the heart, which is interesting, it's where our great vessels emanate from or go into. And so it's kind of all of this area back here in the base of the heart is more posteriorly located. Everybody wants it to be anteriorly, but the base of the human heart is more posteriorly located. So apex here, base back here, when you're actually holding on to it. Now, I see some really good coronary arteries, and that's what you guys are trying to actually uncover in your specimens this week, if you haven't already, is to uncover the coronary arteries on your pig heart. Your pig will have a beautiful right coronary artery. It will also have a beautiful anterior interventricular coronary artery. And why do I say anterior interventricular coronary artery? Because there's a posterior interventricular coronary artery. So don't forget, you have to, especially when there's more in a similar area, you have to include anterior with the name and posterior with the name. Now, the anterior interventricular coronary artery is obviously going off to the apex of the heart. And it's typically easy to find because it's in the interventricular sulcus, correct? The anterior interventricular sulcus. That's also where you find the great cardiac vein because it accompanies it. It drains from the apex of the heart and goes back up and follows. They kind of meander together. So you have to find both of them. And you have to break through the myocardium, the muscle tissue, in order to actually uncover it. When you're looking at the anterior aspect of the heart, which of the two great arteries leaving the heart do you see first? Anterior first. I see the aorta, but it's not the most anterior great vessel leaving the heart. Our pulmonary trunk, right there, is the most anterior vessel that you see from the anterior view. Now, the reason you see this aorta here is because it comes from behind the pulmonary trunk, and it's big and bold, and it's going to take care of the blood circulation to your body, and it's kind of a hog, it's a stage hog. So it's coming up, and it's going to arch around. Well, if you had long aortas, you guys would appreciate this. But are your aortas long? Anybody got a long aorta in this their dissection with their pig heart? You do. You are lucky because everybody's aorta is about that long, right? Or shorter. A couple of inches long or shorter. And that's good that you guys have that because then that means you probably have decent lengthened pulmonary trunk because also your pulmonary trunk's pretty short in most of the heart specimens. With a decent length of your pulmonary trunk and aorta, then you can find the connection between the two called the ligamentum arteriosum. And the ligamentum arteriosum is not close to the base of the heart. It's a little bit further out. This is a connection between the pulmonary trunk and the aorta and it's a real thing. It's called a ductus arteriosus when you're in utero or in your mother's womb. And that is there because the blood that we would ordinarily send to the lungs for oxygenation when you are in the womb doesn't need to go to the lungs for oxygenation, does it? Where does the oxygen for a fetus come from? The placenta. So we don't want this big bolus of blood going to the lungs. We want to bypass that, and we want to put it back into the aorta and send this blood out to the circulatory tree that's really large, not just lung aspect. So the ligamentum arteriosum is typically where the pulmonary trunk separates into the right pulmonary artery and the left pulmonary arteries. And we know these are arteries because they're taking blood away from the heart. So right pulmonary arteries going to your right lungs, left pulmonary arteries going to your left lungs. And so they typically go under the aortic arch off to their respective sides of the thoracic cavity, correct? Because the heart's in an area in the middle called the mediastinum. So the heart resides in the mediastinum, and we have right lung field and left lung field. And remember, they're in their own individual cavity. Each lung is separated from each other. There is no connection other than what I call the airway tree or the bronchial tree. Now, since we found our anterior interventricular septum, this is a ventricle, I will tell you, and this is a ventricle. What is the anterior-most ventricle that you see? It's the right ventricle. our left ventricle actually makes up the left margin of our heart. What right here, this talks about the right atrium, RA, right atrium. The right atrium has an ear on it, has a flap. Aren't your ears kind of like flaps? And so that auricle is that flappy part. So the auricle is just an anterior manifestation of the right atrium. Our left auricle over there is also another anterior manifestation of the left atrium because your atriums are predominantly posterior structures. Everybody wants them to be anterior structures because they see their little ears, but they are predominantly posterior structures as far as location for you to find them. Other things here is showing you branches of the right pulmonary artery. Well, that came off of this pulmonary trunk, and remember it's going underneath the aortic arch and splitting off to the right side and then also off to the left side. But goes under the aorta if you're going to the right. Let's see, anything else? Oh, marginal artery. Why do you suppose they call it the right marginal artery? Isn't that a margin of the heart as you're taking a look at that? Isn't that the anterior inferior margin of the heart? And what ventricle is that? Right. So that's why it's actually called right marginal artery. If you actually wanted to give this guy a name, what would be a reasonable name to give him? Because that's how vessels are named, reasonable names. It could be a superior right ventricular artery, or you could maybe even call it a anterior right ventricular artery. So those would be reasonable names for a structure such as that. Let's go ahead and now take a look at the posterior side of the heart. Aortic arch, so we have ascending aorta, aortic arch, descending aorta, and thoracic aorta. And then what do you call it when it goes through the diaphragm? You don't call the aorta a name when it goes through the diaphragm? Abdominal aorta. Oh, yes. I never try to give you guys trick questions. I just try to get you to follow the anatomy of things. And then we have aneurysms of aortas, correct? Yeah. And where is the most common area that the aorta has aneurysms? Anybody know here? Yeah, abdominal aortic aneurysm, correct. So, yes. So that's why it's important. Where you are, remember, you will sometimes have name changes where you are. Don't we have a different name for Appleway and Best? It's the same road, but different areas, same thing. So you have to realize blood vessels are like roads, except roads are nowhere near as descriptive as blood vessels are. Okay, so here's our inferior margin of the heart. And on that inferior margin, there is a sulcus, the posterior interventricular sulcus, which is the external manifestation of a structure inside, which is, what's the structure inside? Interventricular septum, correct. And so that's where our posterior interventricular coronary artery is located and the middle cardiac vein is located. Let's see here. IVC, inferior vena cava, and SVC, superior vena cava. SVC means it's draining venous blood to the heart from everything above the heart, and IVC means it's draining venous blood to the heart from everything below the heart. Now, the interesting thing is typically the pig heart has a decent length of SVC and IVC. And what's nice, they both go into a single atrium. Do you know what the atrium is that they're going into? So now we're on the right side of the heart. That would be the right atrium. Absolutely. So IVC and SVC go into the right atrium, and you can put a probe in your SVC and make it come out the IVC. In the human heart, what's important is, and those have some lengths typically on the pig heart, in the human heart, the IVC is really short in the thorax because it's literally sitting on the heart. You guys realize our heart sits on our diaphragm. Do you guys realize that? So our heart sits on our diaphragm. We are a biped. You are dissecting the heart of a quadruped. Do you think their hearts necessarily sit on their diaphragm? Their hearts dangle in their thoracic cavity. Our hearts sit on our diaphragm, and they sit in a sac that's knitted to our diaphragm. What's the sac called that's knitted to our diaphragm? Pericardial sac. So the heart has to stay in its pericardial sac, and our pericardial sac is literally applied to the superior surface of the diaphragm. So because of that, our inferior vena cava, whenever we try to take a heart out and use it for a specimen, always has the super shortest IVC you'll ever find because it's super short in the thorax. If we actually go through the diaphragm and cut down there, then we'll end up with a longer IVC, but that's not typically how things are done. You're in a cavity and you actually will cut things in that cavity in order to bring things out. So that's our IVC and our SVC. Those go into the right atrium, and so the right atrium that you have to realize, isn't this kind of part of the right atrium? All of this stuff back here on this back side is all part of our right atrium. Now let's take a look at the left atrium. And it has here, it says base of the heart. So they're saying all of this is left atrium. Well, the left atrium feeds into the left ventricle. And which ventricle is bigger muscle mass? The right ventricle or the left ventricle? The left. And the reason the left ventricle has such a bigger muscle mass is because it is pumping blood to everywhere else. And the reason I say everywhere else, all the way to your toes, all the way to your scalp against gravity. So the left ventricle is pumping blood to what's called the systemic circulation. And we will get into all these terms in the notes, but we might as well talk about these things as we're going along. So the left ventricle has to pump blood far away. The right ventricle only has to pump blood to the lungs. It's next door neighbors, which actually ends up being inside of a vacuum. And we'll talk about that when we talk about pulmonary circulation, but we're in an area where actually the pressure's quite low. And so we don't have to work so hard to pump our blood out to our lungs. So we're skinnier because we don't work as hard as the big guy that's working hard to pump blood all over the place. So that's one reason, and that's why I always tell my students, when you start to get flummoxed, discombobulated, whatever your favorite term is for, I don't know what the heck I'm doing, and you're doing your heart eval, all you have to do is calm yourself down by left side versus right side. And left side's always going to be, the ventricle's going to be your big clue because the bulk of your heart are your ventricles. You guys realize that already? The bulk of the heart is the ventricles. And so you get to the bulk of the heart and you find the big, thick left ventricle, and then you know you're on the left side, and then right next to it's the right ventricle. So those things keep you properly oriented. The important thing is that what vessels, do you guys remember already from lab, what vessels go into the left atrium? Are they arteries or veins first? Coming into veins. And they're called what veins? Where are they coming from? Pulmonary veins. So we call those guys pulmonary veins. There's going to be some from the right lung, correct? And some from the left lung. So we have right pulmonary veins and left pulmonary veins. And that's why you have in your notes right and left pulmonary veins. That's telling you we're going to enter into our left atrium, and we're bringing blood from the right lungs, and we're entering into our left atrium, bringing blood from our left lungs. And remember, this is oxygen-rich blood, correct? The other thing to always remember, atria are receiving chambers. They are low-pressure receiving chambers. And if you're under low pressure, you don't have to do much. If you don't have to do much, you don't build up much muscle mass, correct? Low pressure receiving chambers. Ventricles are high pressure output chambers. And so that's why they have that muscular mass associated with them. Atria are designed to be distensible. So low pressure things you can stretch or distend. Ventricles, they are not designed to be distensible. They are designed to actually boosh or squirt that blood out into the arterial system that they belong to, whether it's the right, which is the pulmonary trunk, or the left, if it's the aorta. So those are some very basic ways of taking a look at the heart. Coronary sinus. It is a anterior or posterior structure? Posterior structure, what is it between? It's between the atria and the ventricles on the backside. It brings used blood from the heart, so that means oxygen-poor blood from the heart. And what side of the heart should it deliver that blood to? Should it deliver that oxygen-poor blood to the right side or the left side of the heart? To the right side. And so the coronary sinus empties into, lo and behold, the right atrium. So the right atrium actually receives used blood from 3 different sources: SVC, IVC, and coronary sinus. So you should be able to demonstrate that with your probe if you are on the right side of the heart. Quickly, the pericardial sac is really easy to talk about, but it's hard for you guys to visualize because how many hearts had pericardial sacs intact with them? Very, very few. And if they were intact, was it completely around the heart? No. So the pericardial sac truly is, you take a heart, stick it in a sac, and stitch it to the base of the heart, okay? And to get the pericardial sac off, you actually cut it around the base of the heart and pull it right off, easier than pulling off a glove. So it comes off very easily. Now, the sac is going to have a nice lining that's going to be very different on the inside than the external surface. Which is going to have the slicker lining, inside or outside? Inside. And that's the serous pericardium. And the serous pericardium, which is simple squamous epithelium, has 2 layers to it, 2 components to it. Because remember we talked about cavities, because we're now in the pericardial cavity. The layer lining the sac is called the parietal serous pericardium. The layer that goes over the surface of the heart, which was pushed into the sac, is called the visceral pericardium. Also has another name, it's called epicardium. So visceral pericardium is the same thing as epicardium. So heart is enclosed in a sac with 3 distinct layers. Well, I'm just on the inside of the sac. I haven't even talked about the outside of the sac yet, have I? So that's what I'm referring to for 3 distinct layers. We actually have a visceral pericardium, a parietal pericardium, and outside the sac, we have a fibrous pericardium because we want to make that sac strong, correct? And are the fibers going to be dense regular or dense irregular? Dense irregular CT connective tissue fibers for that pericardium. So remember, fibrous, outermost aspect of the sac, so like your grocery sac, the outermost aspect of your grocery sac would be the fibrous pericardium. The parietal pericardium would be the inside of the grocery sac, and if you actually had a heart in your grocery sac, it would be covered with visceral pericardium. So we'll stop there and give you guys a quicker question. We covered actually a lot of material that were